Hi, everyone. I'm Margo Szabo. I'm a psychologist at the Children's Hospital of Philadelphia, and I'm going to be talking about the brain-gut connections, psychological vulnerabilities, and celiac disease today. I just want to mention that I have no disclosures or conflicts of interest for this presentation. And going through a couple of different learning objectives. My first objective is to identify common psychological and psychiatric comorbidities in individuals with celiac disease. Secondly, I hope to describe the brain-gut axis in the context of celiac disease, discuss a biopsychosocial approach to assessing and treating patients with celiac disease as a behavioral health provider. And first, I'll go into reviewing the common psychiatric and psychological comorbidities, looking at both children and adults with celiac disease. So I like to think about celiac disease as well as any other chronic medical condition as being a bit of an emotional roller coaster, in that people experience both highs when they're having positive moods, positive interactions, positive experiences with their disease, but also lows where they might have emotional lows, as well as times where they're feeling more physically ill and may need some more support. And to kind of go along with that, I think about chronic illness as consisting of two different phases. So initially, when someone with celiac disease or another medical condition is diagnosed, that is considered an acute phase, and that's often marked by feelings of stress and fear, guilt and shame, sadness, grief, a lot of negative emotions as you're getting used to having this new diagnosis and what it means in your life. And then as people progress through the diagnosis phase, they make it into the ongoing treatment phase, and that's often marked by prolonged stress, and particularly for celiac disease, because we know that the only treatment is adherence to the lifelong gluten-free diet, which I know has been talked about in some other presentations. We know that that stress of managing that diet can persist for an individual's lifetime. Additionally, we know that celiac disease can be associated with a high treatment burden. And when I think about treatment burden, I think about, as Boyer and colleagues have talked about, patients' perception of the aggregate weight of their actions and resources that they devote to their healthcare, including difficulty, time, out-of-pocket cost, that are all dedicated to healthcare. And for celiac disease, there are a lot of factors that come into play that are associated with this high treatment burden. Oftentimes, there are things like poor treatment adherence, trying to recognize what types of foods, as well as cosmetics and other things contain gluten and trying to avoid them. Some concern regarding the cost of food, concerns about eating outside the home, some lack of education, and limitations in time to prepare the food. Moreover, celiac disease can be associated with impaired quality of life across emotional functioning, psychosocial functioning, and total quality of life when we compare their quality of life to healthy controls. There's also some evidence that people who are symptomatic with celiac disease, so those who are having either GI or extraintestinal manifestations of celiac disease, may have worse quality of life compared to those that are asymptomatic, and that quality of life may improve with adherence to the gluten-free diet. So as I jump into the next couple of slides, I want to spend some time talking about prevalence rates and risk of developing different psychiatric disorders more specifically. And starting off with internalizing disorders and symptoms, these are probably some of the areas where there's some of the strongest evidence of associations with celiac disease. So compared to both healthy controls for pediatrics and adults, we see higher rates of depression and mood disorders and anxiety. More specifically, for depression, we see higher rates of depressive symptoms, as well as specific depressive disorders such as major depressive disorder and dysthymic disorder. However, I want to point out that we don't have the literature at this point to suggest any association between celiac disease and bipolar disorder. Turning to anxiety, similar to depression, we also see increased risk of anxiety symptoms as well as higher rates of specific anxiety disorders such as social phobia and panic disorder among individuals with celiac disease. We also have some beginning evidence that anxiety and depressive symptoms may improve with adherence to the gluten-free diet, but it's important to note that the results of these studies are mixed. It's also possible that individuals with continued anxiety or depression symptoms may have difficulties with adherence to the gluten-free diet. However, it's very impossible to determine whether this is a causal relationship given the lack of experimental studies, and therefore it may be that depressed individuals or individuals who are more anxious tend to be more non-adherent rather than vice versa. Within this internalizing disorders literature, some potential mechanisms for these high rates are poor general well-being, as well as physiologically based mechanisms such as vitamin deficiencies prior to diagnosis. Following diagnosis, difficulties with dietary restrictions, as well as impaired social relationships may contribute to these high comorbidities. Turning next to externalizing disorders, we do have fewer studies conducted on the prevalence rates of these disorders within celiac disease. However, for children, we note there's an increased risk of generalized physically aggressive behavior, as well as higher rates of disruptive behavior disorders. Similar to some mixed findings in internalizing disorders, we also see mixed findings related to ADHD and celiac disease, with some studies suggesting a significant association, while others do not find such an association. And similarly to the internalizing symptoms, there is some evidence that ADHD symptoms, specifically in adults, may improve with adherence to the gluten-free diet. To hit on a few more psychiatric disorders, I'm going to spend some time talking about these next couple here on the slides. We have found that there is a bidirectional association between celiac disease and eating disorders, such that individuals with celiac disease are at increased risk of developing eating disorders after diagnosis, and vice versa, those with eating disorders may be at increased risk of developing celiac disease. Specifically, some rates of eating disorders may be as high as 15% in youth with celiac disease, but I will note that that is based on one study alone, and as a result, more studies need to be done, particularly on avoidant restrictive food intake disorder, which has newly been added to the DSM. Additionally, we see greater rates of intellectual disability in youth with celiac disease and higher rates of autism spectrum disorder in both pediatric and adult celiac disease. Some suggested mechanisms for the relationship between autism and celiac disease are increased intestinal permeability and nutritional deficits. Although there is no increased prevalence of psychotic disorders for children, it's possible that the lack of association is due to the low prevalence rates of psychotic disorders in children. Additionally, there has been a link between schizophrenia and celiac disease found in adults. And I would also like to point out that even though there are studies that found no association between celiac disease and psychiatric disorders, we clearly still need some research on this area. And some people have suggested, such as Coburn and colleagues, that studies with no significant association may be conducted in countries that have better supports for celiac disease, such as subsidized gluten-free food. Now we'll turn our attention to discussing the brain-gut axis, which may help to explain some of the psychiatric comorbidities in celiac disease. To start off, the brain-gut axis focuses on the bidirectional communication between the central nervous system, the brain, and spinal cord, and the autonomic nervous system, which is divided into the sympathetic nervous system and parasympathetic nervous system, the hypothalamic, pituitary adrenal axis, and the gut. It's also important to point out that the digestive system is the only peripheral body system to have its own nervous system known as the enteric nervous system. We know that the communication between these different symptoms can play a large role in emotional functioning. For example, having a chronic GI condition can certainly cause anxiety. People worrying about access to a bathroom or whether there are gluten-free options available at their favorite restaurant. On the other hand, chronic activation of the stress response can alter the brain and gut chemistry and put an individual at risk for developing increased GI symptoms. There are several mechanisms that discussed within the brain-gut axis, and I do want to point out that most of the research done on the brain-gut axis is within the area of functional GI disorders and inflammatory bowel disease, but we can help to generalize some of these findings to celiac disease. Listed on the screen are the three main mechanisms of the brain-gut axis, and in the next few slides I'll discuss each of them in more detail. Starting off is pain processing, and one way in which pain processing is altered in GI disorders is visceral hypersensitivity. I think about visceral hypersensitivity as heightened perception of sensory input in the gut and intestines that is not typically perceived consciously. So being very aware of things like our normal digestion and motility that happens for most of us without even recognizing it. The graphic on the screen gives a good depiction of what this may look like for someone, in which they have an enhanced perceptual response to normal sensations. So they might say, ooh, what was that rumbling in my stomach when they're hungry? And what may happen is some GI-specific anxiety, so some worries may come up. Rumbling is bad, right? Rumbling means that things are moving too fast in there. Am I going to have time to get to the bathroom? And there isn't one in sight. Am I going to have to leave the restaurant? Different things like that. And then what tends to happen is behaviors that may be out of proportion to the symptoms. So I think it's better if I just leave. No one understands me. Why do I bother going out? When we look at the stress response system, that consists of the autonomic nervous system and the hypothalamic pituitary adrenal axis. Specifically, as I mentioned before, the autonomic nervous system is divided into the sympathetic nervous system, which is responsible for the fight or flight response that most of us all know and love or hate at times, as well as the parasympathetic nervous system, which activates our rest and digest response. So what we see with the stress response system in our typical pathway is that a person encounters a stressor, which activates the hypothalamus. The hypothalamus then activates our sympathetic nervous system or our fight or flight response, releasing epinephrine into the system. If the stressor passes, the rest and digest response kicks in. However, if the stressor continues and is more chronic, the hypothalamus activates the pituitary and adrenal glands, which release cortisol. And this may happen again for longer-term stressors or ongoing things like being stressed about where you're going to find gluten-free alternatives to eat. We also know that the stress response system communicates with our enteric nervous system. And through that communication, the stress response system can impact intestinal mobility, secretions, and intestinal permeability. Moreover, we know that the intensity and duration of stressors can play a role in this communication and how it is interpreted within our GI system. Lastly, we want to think about the gut microbiome. So our microbiome within our digestive tract includes thousands of microbial species in the gut. What's quite interesting is that Similar to some of the other systems I've talked about, there is bidirectional communication with the central nervous system via both the endocrine systems and the autonomic nervous system. And what we see is that the central nervous system can, in fact, change the composition of the microbiome, which then further impacts intestinal motility, visceral sensation, inflammation, secretion, and permeability. And a change in this microbiome is linked to the development of GI disorders such as celiac disease. On the flip side, our microbiome can impact central nervous system function and in turn alter an individual's behavior. Specifically, a study done with infants in celiac disease noted that early life stressors such as cesarean section delivery can impact the microbiome in the gut. Finally, I just want to point out a couple of different neurological complications of celiac disease. So first off is gluten ataxia, which includes eye and gaze movement disorders as well as dysarthria. And this is thought to be due to dysfunction of the blood-brain barrier in celiac disease and gluten sensitivity. We also know that peripheral neuropathy is present in celiac disease, and with the gluten-free diet, there is some evidence to suggest improvement in neuropathy, but the results thus far have been mixed. Additionally, we see complications with epilepsy and headaches, as well as brain fog and what's known as the hyperexcitable celiac brain, which comes up in the form of abnormal EEGs, abnormal brainstem activity, and electrocortical patterns. And to point out some of the brain fog that we may see commonly in celiac disease are things like concentration and attention difficulties, episodic memory deficits, word retrieval issues, and reduced mental acuity. So given the information presented thus far, I find that it's most helpful to assess and treat patients with celiac disease using a biopsychosocial model. And I'll spend the last couple of slides reviewing and applying this model to a case example of an individual with celiac disease. So as you see on our screen, the biopsychosocial model, and as the name suggests, includes biological, psychological, and social components. We know that it is important to think about the biological processes at play when we think about celiac disease. That's how we know that, in fact, the gluten-free diet does treat the symptoms of celiac disease and lead to intestinal healing. But it's also important to recognize that individuals with celiac disease do not live in a vacuum, and therefore we must consider both their social context and potential psychological processes at play. I also find it helpful to think about not only the risk factors that may come up in these different areas, but to also think about the strengths and resources that an individual with celiac disease may bring to the table when I'm conducting my assessment and treatment. Looking first at the biological, physiological processes, you'll probably recognize a few of these from the slides on the brain-gut axis. So we've talked about pain modulation and visceral hypersensitivity already. We've also talked about the gut microbiome in depth. Of course, we know that adherence to the gluten-free diet helps to heal the intestines and may decrease symptoms of celiac disease. Additionally, maintaining healthy habits such as adequate sleep quality and quantity is associated with good overall physical and mental health, and thus is important in patients with celiac disease. Finally, comorbid medical diagnoses may not only impact the adherence to the gluten-free diet, but may cause additional physical symptoms and complications. Looking next at the social context, when we look at the research on functional gastrointestinal disease, we see that there's a higher prevalence rate of adverse life events, such as trauma and abuse. However, more research is needed in celiac disease, but even still, these are important factors to consider. being teased and ostracized by peers as a result of the gluten-free diet may surely come into play with individuals. We also want to consider an individual's cultural beliefs, including those about doctors, hospitals, and medical care that may impact a person's access and adherence to care. As I mostly work with children, we always think about that children, similarly to any person, do not exist in a vacuum, and that we always think about them in the context of their families and additional support. So we want to take into consideration parental behaviors that may reinforce the sick role and increased impaired functioning through school absences or lack of participation in social events, as well as family beliefs and misunderstanding of the gluten-free diet. I think about school or social support being either a risk factor or a potential resource based on the amount of social support and the types of social support someone has for poor or good coping. And for children in particular, the school environment is very important, thinking about the school staff's understanding and willingness to implement accommodations for celiac disease, which is discussed in greater detail in Dr. Coburn's presentation. Lastly, we want to think about the psychological processes at play. As I spent the majority of the presentation in the beginning on, we know that there are a number of psychiatric comorbidities in celiac disease, such as depression and anxiety, that can be associated with poor adherence to the gluten-free diet and vice versa. We also briefly touched on GI-specific anxiety, which may alter both brain and gut functioning, causing more GI symptoms. Things such as the negative attentional bias and catastrophizing may also lead individuals with celiac disease to avoid situations in which there's a chance of cross-contamination or gluten exposure and negatively impact functioning, such as missing out on social events with friends, refusal to go to school, missing work events. Having adaptive coping skills for anxiety, stress, and low mood can also be a great strength for people, as well as different personality traits which may either help or hinder individuals with celiac disease. For example, someone with perfectionistic tendencies may be very aware and reread labels many times to make sure they're not ingesting gluten, which of course we want them to do, but we also want them to be able to focus and enjoy other things in their lives and not allow all their time to be consumed by those obsessive behaviors. So taking all this together into context, I want to talk about a case of a 15-year-old female that I've seen with celiac disease. So if we look into the biological processes, of course, this woman had celiac disease. When I met with her, she had started on the gluten-free diet several months ago. And according to her and her family, they were mostly adherent to the gluten-free diet. There were a few instances of some accidental gluten exposures and some instances of cross-contamination among family members, which with additional education seemed to be resolved. This person also presented with some visceral hypersensitivity. So she was a girl who had described those sensations of feeling food digest and feeling food move through her gut and concerned that something was wrong or that maybe she had ingested gluten accidentally when in fact it was the sensitivity of her gut. Within her social context, she had a history of peer victimization and bullying, teasing for a number of other issues that were not necessarily related to her celiac disease, but there was worry among her family that her adhering to the gluten-free diet would cause more issues with peers. Parents also engaged in what I would call a protective responding style, where they often monitored and closely checked in on her regarding symptoms after she had eaten, making sure she was feeling okay before going to school in the morning. On the positive note, she did have a very supportive school staff who did seem to understand celiac disease with additional education and were very willing to make accommodations, ensuring she had access to gluten-free foods in the lunchroom as well as at any special events. In the psychological realm, she also had a history of separation anxiety, which had since been treated. So from that end, she had relatively good insight about the role of anxiety in her symptoms and was able to talk about times when she may have been overinterpreting some of her visceral hypersensitivity symptoms that may have in fact been anxiety. She also engaged in some dietary restriction, given concern about accidental gluten exposure or cross-contamination, and had some GI-specific anxiety. So as you can see, all these things are important to take into context when you're treating an individual with celiac disease. In conclusion, individuals with celiac disease are at elevated risk for psychiatric comorbidities and poor quality of life. Some studies suggest that up to 22% of individuals with celiac disease may go on to develop psychiatric or neurological complications. Additionally, youth with celiac disease may have rates of psychiatric symptoms and disorders over 1.2 to 1.8 times higher than healthy children. It's important to think about the mechanisms within the brain-gut axis that are relevant in the context of celiac disease, including pain modulation, the microbiome, and the stress response system. And finally, the biopsychosocial model can help guide mental health providers in the evaluation and treatment of celiac disease. Thank you guys for joining me on this presentation, and I'll leave my references up for you to review.